Welcome. The University of Melbourne acknowledges the traditional owners of the unceded land on which we work, learn, and live, which is the Wurundjeri people of the Kulin Nation. We pay respect to elders past, present, and future, and acknowledge the importance of Indigenous knowledge in the Academy. We acknowledge that sovereignty was never ceded. We also extend this respect to all traditional owners of the land from which our participants are joining us. So, hello and welcome to our first Center for Digital Transformation of Health seminar for 2026. I'm Professor Peter Steele, the Director of the Center for Digital Transformation of Health, Associate Dean, and Chief Transformation Officer at the Royal Melbourne Hospital. The vision for the center at the University of Melbourne is to be a trusted partner and convener in this circumstance in health innovation, catalyzing the responsible use of data, digital technologies, and AI, and the safe and equitable development and adoption of these innovations, as well as a workforce confident and capable in driving digital transformation. The center brings together a world-class research platform and an education team working alongside researchers, clinicians, and commercial collaborators to responsibly accelerate digital transformation across healthcare. And in these seminars, we're excited to bring attendees from across that diverse ecosystem, clinicians, healthcare administrators, researchers, industry partners, government sectors, to hear from leaders in the field of digital transformation globally, particularly through case studies and research findings, and then practical tools and approaches. So before I introduce today's speaker, just one more piece of housekeeping before we begin. Would like to leave enough time for Q&A at the end, but please try and put your questions not in the traditional Zoom chat, but in the Zoom Q&A function. And then I'll pick out some of those questions. Hopefully we'll have time for a few to continue the conversation with Dr. Wardi. So just moving on so today we're delighted, and I am very personally delighted to be hosting Dr. Gabriel Wardi, Associate Professor and Chief of the Division of Critical Care at UC San Diego. He'll be speaking on improving sepsis care through AI and all the lessons that UCSD has in their journey. Dr. Wardi completed his undergraduate and graduate education in Atlanta. He moved to San Diego for his residency in emergency medicine, where he also served as chief resident during his final year. He's the first graduate of the Joint Critical Care Medicine Fellowship offered by the Division of Pulmonary and Critical Care and the Department of Emergency Medicine combined. He joined the faculty in 2017 and attends in both the emergency department and the ICUs in UCSD as an associate professor and founding chief of the Division of Critical Care. Dr. Wardi's research interests include sepsis, the ED-ICU interface, resuscitation, cardiac arrest management, and importantly to today, the use of machine learning to improve patient-centered outcomes. He is currently funded by the NIH to study how big data and machine learning can improve outcomes of sepsis patients. He oversaw the clinical implementation of a novel deep learning model to predict sepsis at UC San Diego, which resulted in a 17% relative decrease in sepsis-related mortality. This work has been acknowledged by the White House, and Dr. Wardi has received various awards for teaching and mentoring. Has been selected as one of the top doctors in San Diego multiple times. He's also a great personal friend, so Gabe, thank you for coming today and welcome to this community. And we very much look forward to hearing your lessons and having a conversation at the end today. Over to you.
Perfect. Well, first of all, thank you for the very kind words. And it was a little bit of a surprise to me that it's actually the 27th of May, where you guys are, because where I am, it is still the 26th. And I'm just leaving the hospital. So if you hear any weird noises, I apologize about that. Just in terms of disclosures, as you heard from Dr. Steele, I am funded by the NIH. I've also received funding from the National Foundation of Emergency Medicine, and I've done consulting for Abbott Laboratories, but we're not going to talk about anything related to Abbott work today. And There's three main objectives of the talk that I have here. The one freebie that I'm putting in here is just to remind people about why sepsis is so important, since that has been the primary thrust of my academic career. But we're really going to talk about how we can use machine learning and AI applications to actually improve care. And again, I think, one of the big takeaways that you heard in my introduction is we're going to talk about how we were able to use an AI tool to improve outcomes in sepsis that I think has eluded a lot of places and a lot of the lessons learned along that journey there. So I always like to start with a picture of this young boy. I don't expect any of you here to know who this is, except perhaps Dr. Steele. But the story here is that this is a young man named Rory Stanton. And unfortunately, Rory died of sepsis about 12, 13 years ago in New York State. And I think if we look at how modern medicine has done so many wonderful things, the question still remains how we can let someone like this, that's an otherwise healthy 13-year-old boy, have multiple trips to an emergency department to be discharged home, only to come back a few days later and die of septic shock at one of the best institutions in the world. And I think that's a guiding principle about how we can use AI to improve patient care. Now, of course, we are going to talk a lot of sepsis here and just some brief, like I said, one of the freebies that we're throwing in here is what is sepsis and why is it such an important condition to manage? Sepsis comes from Greek. It means to rot. And I think the best way to define it in today's day and age is to think of life-threatening organ dysfunction from a dysregulated host response to infection. And one of the inherent challenges that we see when it comes to studying sepsis, both with and without of the AI domain, is we have a lot of different definitions that try to reflect this. And harmonizing that to something that's useful remains quite challenging in the current world. Of course, why is this important? Well, in the United States, we can tell you there's 1.7 million cases of sepsis a year. Worldwide, we know there's about 50 million cases a year, of which about 11 million people or so die each year. And those numbers are from the late 20-teens. So you can only imagine that with an aging population, more and more complex medical conditions, that we're seeing more and more sepsis, and it remains an extremely common and costly condition. Now, if you also ask yourself how we've historically managed sepsis, any of you that take care of patients have probably said, yikes, there's not that much different that we've done in the past decade. And you're exactly right. This is a picture from Harrison's Internal Medicine book from 1973. And you can see the resuscitation strategy that we have when patients come and are initially identified as septic. And it's honestly not that different than what we do now. We give them some fluids. We track to see, is that fluid doing something useful? We give them early antibiotics. We start them on vasoactive medications. We still debate the utility of steroids in patients. And back then, we would transfuse them for hemoglobin targets. We've realized that doesn't make that much of a difference. But the point here is in 1973, we are largely doing the same thing, and we haven't had any paradigm shifts in how sepsis care is done. And indeed, this is what we know, how we manage sepsis in the United States. We still focus on sepsis bundles that, while they might be a little bit more targeted compared to what was done in 1973, it's frankly not that much different. And this is a piece that we put out in Annals of Internal Medicine last year, where we did a systematic review to take a look to see if the national quality metric that dictates sepsis care in the United States had any impact on outcomes, or if we could find even some high-level data that suggested this was actually moving the needle. And the answer was there wasn't really any high-level data that suggested there was benefit. And the majority of studies put out there showed that the national quality metric that dictated a sepsis bundle in the United States was not associated with improved outcomes. And that really begs the question, why should AI be used in sepsis? And I think this is one of these domains where there's been tremendous interest. But if you think about it, sepsis is a heterogeneous syndrome. It's not a single condition, but rather a constellation of signs and symptoms that is incredibly complex. And for the most part, we do very well at picking up on sepsis, but it's the cases that are subtle that we miss that can have catastrophic outcomes, much like the case of Rory Stanton. We also know that sepsis is a very time-sensitive condition, particularly in the more severe forms of septic shock. Every hour delayed in antibiotics, mortality goes up by about 7%. But something else that why I think AI is a very good approach for sepsis is we've seen in the past probably 40 years or so since I've shown you that slide, there's been close to 200 or so novel therapeutics that have attempted to change outcomes in sepsis, and they've all failed. And so we haven't moved the needle as much as we'd like to see in sepsis care. And that, of course, brings me to why this is a very exciting time in medicine. And this is an image right here of Thomas Kuhn. If you don't know who Dr. Kuhn was, he was a classically trained physicist, but he wasn't known for his work in physics. He was known for his work called The Theory of Scientific Revolutions, where his thesis was that scientific advances do not happen in a linear process, but rather in paradigm shifts. And I think that's where we're at right now with sepsis. And we've started to see more and more data that we're actually starting to move the needle. And what we're going to talk about with the rest of this is some examples of how this can actually be done. And I think for this group, you're probably all well aware and very, very interested in the applications of artificial intelligence. And I think in medicine, to be honest, we're sometimes a little bit behind or a lot behind compared to how every other group is using medicine. If you're also scrolling on Instagram or Facebook right now, all the things that are popping up on your feed are chosen by very elegant deep learning models to predict what you're going to want to scroll on. And they're pretty darn effective at keeping you engaged when you shouldn't be looking at them. And that's why I think it's exciting what we've done here at UCSD. So we're going to switch gears now and talk about some of the classic examples about how machine learning has been used in sepsis. The first example, the first manuscript we're going to dive into is called an interpretable machine learning model for accurate prediction of sepsis in the ICU. There's a few reasons that I think this paper is worth highlighting. The first is that the first author here, Dr. Shamim Namati, is one of my mentors. But probably the more compelling reason is this is one of the first examples of how machine learning could actually predict sepsis in an intensive care unit. So what did they do here and why did people get excited about this? Well, they were one of the first groups that took advantage of big data. And again, this paper was published in 2018, where large data sets were coming up, but not quite commonplace. So they took advantage of the rich ICU data repository at Emory University. They combined it with Mimic3 from Boston. And they wanted to take a look at common input features that are available in the medical record and some waveforms to see if they could predict sepsis about 4 to 12 hours ahead of time. And this event horizon was chosen very, very carefully because if you think about it, if a model tells you that someone's about to develop sepsis in the next 30 minutes, you've probably missed the boat, right? You probably could have done something to stop that. But once you start getting more than 12, 24 hours, clinicians say, yikes, unless this model is perfect, I'm not really sure what I'm supposed to do right now. So this is the approach that they took. And again, if you aren't a machine learning expert, this is just kind of the approach they took with using a structured machine learning model with supervised learning to predict sepsis. To go through the approach they used back then, and we'll talk about the updates, right? What we've used here, building on this, was a modified Weibull-Cox proportions hazard ratio. But really, what they wanted to do is to train data, predict, like I said, to predict sepsis 4 to 12 hours ahead of time, and they validated it on a probably about 20 or 30% of leftover data they had from their initial training set. And what got people very excited at this point was that they were able to show with a fixed sensitivity of 0.85, an AUC of 0.86 for predicting sepsis 4 to 12 hours ahead of time. Now, this is something that at that point really kind of threw this on the map as something that people should pay attention to. Of course, there's a few caveats with this. One thing they chose to do ahead of time was to have a fixed sensitivity, relatively high at 0.85 to make sure this is functioning as a screening test, not for something that would miss sepsis going through. I also like to point out to Dr. Namati every time I present this slide is that even though he is incredibly intelligent, his spelling of sensitivity still had much to be desired at that time. But the key takeaways from this were first that it was a retrospective observational study. And I think it's a classic study in this domain, but they really did not address what we all care about now, which is how this could be implemented to improve patient-centered outcomes and how this could be generalized to other sites. An interesting point that they also found was that even when the model said that a patient was likely to develop sepsis in the next 4 to 12 hours, And they did not end up being sepsis or septic. They had a high mortality rate. And put another way, if the model said this person is septic and they weren't, it was usually going to be something like the patient was developing a gastrointestinal hemorrhage or developing worsening respiratory failure or having a myocardial infarction. So something that would be clinically significant in the patient's care, but not quite sepsis. And at least that the miss would be something that would be respectable, so to speak, where evaluation would be useful. So the second study we're going to talk about was published in JAMA in 2019. And why I think this is a particularly important one is this is one of the first times when we started to see phenotypes pop up for sepsis, where we could talk about more precision medicine. But also, if you take a look at the authors and you take a look at the journal, JAMA is largely considered one of the preeminent medical journals. And the first author is probably Chris Seymour is probably the most well-respected young to moderate career sepsis researcher out there. And what they wanted to do is to take large data, and again, you can see close to 90,000 patients, take commonly used variables that are readily available in any emergency department, things like basic demographics, age, sex, inflammatory markers, markers of organ dysfunction, but also take advantage of the fact that at the University of Pittsburgh, they had a robust system of clinical trials with biomarkers of host response. And they wanted to go through and see how they could use this data to develop phenotypes. And again, this is just the conceptual model. If you do not follow much machine learning, the approach they use is called consensus k-means clustering, which is a relatively commonly used one. And they went through and through this unsupervised approach, asked the model to spit out different phenotypes just based on the input data. What got people very, very excited about this, besides the beautiful chord diagrams that they generated, was that they came up with 4 distinct phenotypes, one of which, the delta phenotype down in the bottom, had worse outcomes associated with fluid resuscitation. And like I showed you, fluid resuscitation has remained a cornerstone of sepsis care over the past decades. And if it's possible that we are causing harm through a very, very accepted therapy, we really need to rethink about how we're approaching sepsis patients to try to identify this group. So to summarize this one, again, the big thing was we could now identify clinical phenotypes that had a degree of biologic confirmation. We saw certain populations harmed from fluid resuscitation. And importantly, this was a retrospective study, although it took advantage of a very, very large data set from very, very respected researchers. But it really begged the question, would this actually impact clinical care? And what would a prospective implementation look like? And both of these studies, despite the fact they've been cited about 1,000 times each, really kind of push this to make us think about how we can actually use these in clinical care and what's the benefit to the patient. And that's where we're going to switch gears right now and talk about our experience about how we've used machine learning at UCSD to improve outcomes. And I think one thing that any of us who follow AI use in healthcare is we talk about the chasm that we see between what we can do in silico and what we're actually clinically doing. And this is something that is quite unfortunate because there's all number of wonderful things that I think most of us agree could probably improve patient care, but we don't use them clinically, and we haven't been able to test and measure the impact of these tools on how we administer care. So really bridging this has been a major goal of what we've had at UCSD. One of the questions that we're going to address when we talk about some of our homegrown models is how actually does AI end up in the EHR? And if you're like most shops in the United States, and I assume Australia, the EHR vendors that you work with provide modules. These are usually free and very heavily incentivized by the vendors themselves to use them. There are some standalone products that can be incorporated into them. These are far fewer. And really, there's a very, very small number of what I'm going to call the homegrown tools. And that's what we've developed at UCSD to help with sepsis care. But these are quite difficult because it really requires a very complex and multidisciplinary approach to kind of bring these tools from the development to the implementation into clinical care. And of course, one of the things that I was very fortunate enough to work with was at the time, a PhD student named Dr. Aaron Busina. And Aaron got his PhD with us just about a year and a half ago. And a major focus of his PhD thesis was how we can actually take data from our EHR, and we use Epic here at UCSD, and how we can securely get it into Amazon Web Services using Fire, run the computations, and then get it back into our electronic health record. And this has really formed the basis of what we're able to do here at UCSD. And I actually remember meeting Dr. Steele, I want to say 5 or 6 years ago at a conference in Philadelphia. And he said, yikes, you guys have actually solved this riddle about how to get data there. And a lot of it is thanks to Dr. Busina that you can see his image right here. But we've been very fortunate to kind of take advantage of the setup that we have. And we're going to talk about the model that we use at UCSD. And the model that we use is called Composer. On the technical aspect, this is from an earlier paper we put out in Nature Digital Medicine in 2021, where we described one of the key features of this. And one of the reasons that we've been very excited about the use of Composer is we use something called conformal prediction. And in this, when we start to ingest clinical data, if the model does not recognize the data that it is seen, it does not generate a prediction, but rather it suppresses any kind of alert. And probably the simplest way to think about this is if a nurse inputs the heart rate for a patient is 1,000, there's no generation of a prediction, but rather that is suppressed because the model does not recognize that data. It's not in its conformal trust set, so to speak. And so that ability to reject data when there's some uncertainty and it doesn't fit what the model has seen becomes quite important in making sure that we're generating trust with providers. Now, when we were developing this is built on over 500,000 patients between UCSD and Emory to kind of develop a very, very robust model. And with that, the AUC that we were able to generate for predicting sepsis 4 to 6 hours ahead of time was about 0.95, 0.96. So really taking advantage of a lot of very good computational approaches, but also a very, very large data set. And again, right now, if you were to walk into UCSD and you checked into our emergency department, what would happen is we start to abstract data on an hourly basis. And our Composer model right now takes about 150 or so variables on an hourly basis, things like basic vital signs, past medical history, comorbidities, and it starts to generate hourly predictions about the potential for sepsis. Like I said, we have a conformal prediction model that we use that rejects any kind of data there. But what we also spent quite a bit of time was developing appropriate suppression logic to make sure that the model was not frustrating providers. And I think anyone that's ever worked in an emergency department or hospital wards or an ICU or an outpatient clinic is very familiar that a lot of times alerts will tell you something that you already know. And so that suppression logic, in our case, when patients had already been started on antibiotics or already had a sepsis bundle completed to make sure that we were not receiving an alert became absolutely critical. We'll then talk about the silent trial in just a little bit, but that's kind of the basic format that we have here at UCSD right now. So what is the silent trial and why do I think this was absolutely critical in having effective implementation of the Composer model at UCSD? Well, if you want the definition, and I think the paper I put here is probably the best example of, of a description of what it is. But if you think about it, it's a prospective non-interventional testing of AI models in the intended clinical setting without affecting patient care or institutional operations. Put another way, what this meant was for 9 months before we went live with our Composer model, we had a weekly meeting where we would see exactly when the alert was firing, take a look to see under what situation that was, and then I would oftentimes call the providers in the emergency department and say, hey, we're testing this model right now, an alert fired. What's your take on this? And it was very useful to hear the feedback from providers if they would think that it was a valid alert or not. And it really shaped a lot of the suppression logic that we did. And I think this is one of these oftentimes forgotten approaches before going live with a mature model in clinical care. And I can tell you the amount of suppression alerts that we add, or the number of suppression logic that we put in because of this really helped make sure that we weren't annoying our providers. So something very, very important that's often overlooked. We also adopted a very, very good framework, and this is what was recommended to me by some implementation science mentors. There are a number of these out there, but the one they suggested was called the EPIS framework. It stands for Exploration, Preparation, Implementation, and Sustainment. And with the model that we had called Composer, we were very explicit up front with what we wanted to do. And this wasn't a one-size-fits-all sepsis prediction, but rather to function in the emergency department to catch patients where there was diagnostic uncertainty and they not yet had a sepsis bundle started. So with that idea of what we wanted to do, we then entered the preparation stage. And I think probably the hardest thing here is convincing hospital leadership that the idea you have is worthwhile and can move the needle. We were very fortunate that our chief medical officer at the time, a guy named Chris Longhurst, was very excited about this. And to be honest, we had a much easier experience than most people have because he was ready to go from the start and very helpful with removing barriers. But it's something that a lot of people forget is that if you don't have buy-in from the higher ups, that actually getting this to the bedside can be quite difficult. And then with a lot of excitement, we decided to go live. I remember very distinctly, we went live on December 6th, 2022, because I was terrified that after all this work and many, many grants and many, many people putting investment in this, that we would have a failed model. But fortunately, we'll talk about some of the benefit that we had. And what I think is probably the hardest phase is the sustainment phase, to keep people engaged, to remind them of the importance of what you're doing. And in terms of the bodies that are engaged with sustainment compared to the other phases, it is far fewer. And reminding people day after day to use something becomes quite challenging because they're like, yep, I remember that. I'm on to the next thing. So the BPA that we developed is right here. This is something that there was a lot of work with our nurses that we built with them. And I think it does a few things very, very well. One is it gives them a little bit of education on sepsis. It also gives them the opportunity to open up an order set if they are worried. And it also kind of gets at a little bit of the interpretability of a machine learning model. We give them the top causes, and we'll talk about how we've advanced that using a large language model in not too long. But what we also did that I think was quite smart was we were the first BPA at UCSD where we actually gave the end user the ability to open up a message and send it to the treatment team. And you can see me every time that this fired off to help getting that message from the end user or from our nurses that receive this to our physicians. And I still get messages on this, but I think it's been a very, very helpful component of making sure that implementation stays there. This is some data that we went back and actually took a look to see how well our BPA was received by the end user, our nurses. And I think there's two things I want to highlight here. The first is that we actually avoided the dreaded, let me just get out of this notification. Less than 10% on the 5 months that we studied this actually did that, just X'd out of it. But what we also found that made me really, really happy was that we had greater than 50% of our nurses would actually transmit this to our physicians, suggesting they saw some kind of benefit about this. But I think that's something that, in terms of the effectiveness of the tool, that really argues that people found value in it. And of course, this is what got, our paper in Nature Digital Medicine in 2024, is that after we went live with this, using causal impact analysis, we were able to show a 17% relative decrease in mortality compared to what would have been expected. Of course, that's a somewhat nebulous term, and to put that in terms of lives saved, since we've gone live with this, it's been about 4 to 5 patients a month that come to UCSD through our emergency departments that are alive when before this model, they wouldn't have been with sepsis. So it's a very impactful number right there about how using this model intelligently has actually impacted outcomes here at UCSD. We also saw in terms of the mechanism of why this might have happened, we did see an increase in our internal bundle compliance, a 10% relative increase or about a 5.9% absolute increase. And probably most importantly is that we saw when our nurses transmitted this to our physicians, we saw there was a significant decrease in the time to antibiotic administration. And although the bundle compliance is nice to see, I think this is probably the key point, is that when our alert went off and the nurses were worried about this, our providers actually got more timely antibiotics there. We also saw there was less organ dysfunction at 72 hours. And on the health systems level, we saw a trend towards less ICU admissions and decreased length of stay, although it did not meet significance. So that's the first story that we have about, kind of building up a model that started with that 2018 publication with Dr. Namati and kind of serial upgrades and bringing it into clinical practice. The second example that we're going to go over is how we can use AI for quality improvement. And I'm guessing that in Australia, you're probably a little bit more cost effective and don't spend as much time as quality as we do in the United States. But this is these numbers of $5 million a year and over 100,000 hours come from Johns Hopkins that they published in 2023. And we started to ask the question, could we use large language models to automate a lot of these very mundane tasks? And I remember very distinctly having a conversation when I was on a walk one night with Aaron about how we could maybe use this to augment quality of care. He was super excited about it. I was super excited about it. And we really wanted to see how we could use this to move the needle when it comes to the actual quality of care, but also that measurement that's so, so important. And again, you don't have to deal with SEP1 in Australia. Every hospital in the United States does. And again, this is our sepsis quality bundle. It is a very, very labor-intensive one to assess. It is a 63-point binary process measure. It takes an expert reviewer about 2 to 3 hours per case to go over. And because it is so complex, there's a lot of disagreement between different reviewers about different components of the bundle. One of the other challenges with this, though, is that because it is so time consuming, that oftentimes at most institutions in the United States, feedback to providers is administered at least 2 to 3 months after care of the case they provided, which is pretty useless because most physicians cannot remember the patients they take care of a few weeks ago, let alone a few months ago. So that was what we wanted to test using a large language model. And this is a paper we put out in 2024 in NEJM AI. And there was a very simple question. Of 100 cases that had undergone expert review by humans, could a large language model approximate that agreement with SEP1 compliance? And so of these 100 cases, we found agreement was 90% between 2 human reviewers and the large language model that we used. And what was even more exciting was we found that the LLM was right in 4 out of 10 of the discordant cases. And importantly, this only took minutes to evaluate these 100 cases. So certainly very, very exciting there. But again, much like the 2 cases that I showed you initially of Dr. Namati and Dr. Seymour, this was purely retrospective. We didn't measure how this actually impacted clinical care. Which, of course, brings me to something that I think that all of us in medicine recognize is that we do a pretty crappy job at actually understanding how well we perform medicine. We all think, or at least I think, that I'm better than the average physician when it comes to working in the ICU and the emergency department, that I'm more procedurally competent, but I have zero metrics to actually back that up. But if you think about sports, for example, and this is a famous San Diego Padres baseball player, he knew every single statistic about how he played throughout his very, very long career. Everyone in business, finance, law, everyone knows their own metrics. But in medicine, we don't really have a good understanding just because it's so complex and so time consuming. So this is what we wanted to test was, could a large language model actually improve sepsis quality of care? And it goes back to the question, can physicians actually get near real-time feedback about the performance that they have? And the approach that we modeled this on is something called the audit and feedback strategy. It's a very well accepted approach where you effectively review a case, you give someone feedback about how they do, and on average in systematic reviews, you see an increase in the metric that you're looking at probably about 6 to 10%. But it really begged the question, for instance, if Peter Steele saw how well he did in sepsis care, if he realized that he was missing his fluid boluses, he would probably focus on that a lot more than if he didn't know that information. So that's the question that we wanted to ask. And this is a paper that we have coming out in JAMA Network Open in less than a month. is that by using a clustered randomized trial done at UCSD, where we took a look at all 66 attendings in our emergency department who worked more than 3 shifts a month, if we gave them near real-time feedback using this large language model approach of summarizing the quality of care, pointing out the fallouts and why they happened, or a congratulations, could we move the needle for sepsis performance? And what we were excited about is when we went live, and the way that this worked was that oftentimes I would get an email explaining, from the from Dr. Busina, that contain a daily summary of all the sepsis cases. And I would go through and then assess the fallouts, take a look to see how good the model actually did, if there was any concerns, and then administer feedback to the providers that were randomized to get our intervention. And the key things were, one, is that we found that the model was accurate about, again, that 92% of the time. But we also found was an increase in SEP1 compliance for those that were randomized to get our near audit or our near real-time feedback using the large language model. Now, if you look here, if you ask why this happened, it was largely driven by fluid compliance, and we did not see an impact on mortality. And again, this goes back to that question is the current sepsis paradigm of, how we approach it with fluids, antibiotics, what are we not doing, what are we missing in terms of those game changers, so to speak? But at least showing this compliance becomes something quite important to us because we do get financial reimbursement from the federal government based on how we do. Which leads me to kind of the last bit of our talk about how we're moving here. And again, if you think about how we can maximize artificial intelligence in sepsis, I think where we're at right now is really looking at how we can, the generalizability, how these models that are built at a single institution can generalize elsewhere. I think it's becoming rather cliche now, but certainly super, super important. The implementation science of how these models interact with the unique health systems becomes absolutely critical at getting buy-in and seeing benefit. Prospective studies that we're seeing more and more of these. I've shown you 2 that we've done at UCSD, but in the sepsis space, we're starting to see more and more, including some randomized trials that are showing encouraging results. And governance is certainly something that we don't have time to talk with, but becomes so, so important for how these models are used. So the last little bit I'm going to leave you with has to do with some of what we're playing with right now using another application of large language models. And if you think about it, in medicine, uncertainty is part of what we do. From the first time in early medical school when we learn about a differential diagnosis to how we approach patients on a daily basis until a clear confirmed diagnosis is made. But what would that look like if we could use a digital biomarker to kind of get an assessment of what's going on if there's uncertainty? And that's the latest iteration that we've done with our composer model at UCSD, where what we've done is where the model is not quite certain if sepsis is present or not, to then have an additional model that we add on that abstracts all the available clinical notes and asks a very simple question. Is sepsis on the top of the top 5 of the differential diagnosis? And if the answer is no, then for that case where there's uncertainty, we suppress the alert. And again, a good example of this is one thing that sepsis models traditionally have struggled with to identify is a gastrointestinal hemorrhage. These patients have a high heart rate, they have a low blood pressure, they are tachypnic. That looks like sepsis to anything that is just purely looking at clinical data. But I'm sorry, if you're looking at labs and vital signs, but if you have the clinical context that we abstract through clinical notes and the model's able to quote unquote recognize that the patient is actively hemorrhaging from above or below, then it gives it that context to make sure that the alert does not fire off. And so that's what we've been playing with recently. And you can see some data here that we put out, and this is 2025 in another paper in Nature Digital Medicine, where we were able to maintain the same sensitivity, but our positive predictive value really started to go up once we started adding in a large language model, our large language model module into Composer, which is something that I think adds a lot of value because it goes to getting that provider trust with what you're trying to do. So bringing this all together, you've seen just kind of a basic framework of, some classic studies in machine learning and sepsis, some of the things that we've done. But if you think about it, and this is really where we're starting to move with a lot of other, a lot of other approaches, is to really get a comprehensive understanding of sepsis using some newer techniques to build up chatbots to get an assessment of sepsis patients before they show up to the hospital, to add in additional data sources, particularly through either novel responses of host response or even wearable lactate monitors to kind of get a good understanding to really kind of work to optimize care of sepsis and minimize some of the burden that we've seen with it. And a lot of this is, on the forefront right now that we do have some manuscripts that are coming out describing our experiences with some of these approaches. But I think it's a very exciting time using a very good platform, so to speak, to kind of build on what we've done with the base composer model. So the conclusions that I have before we open this up to questions, first is, again, as someone who has studied sepsis for many, many years, sepsis remains a public health emergency. And I think the application of artificial intelligence is absolutely wonderful to improving outcomes. Obviously, the appropriate intended use becomes critical with how this is being done. But we really do need to focus at this point of, rather than another retrospective model, to kind of push forward with prospective studies that demonstrate benefit, or in cases when benefit is not found, to understand why that shortcoming occurred and ways to potentially ameliorate those for the future. And with that, I will turn it over to Dr. Steele.
Great, thanks, Gabe. That was such a great overview. And there's so much deeper we can go into each of the sections. So I'll try and pick out some questions that covers different parts of your presentations. And we'll maybe start with perhaps an easier, fun one, which is a colleague from the Peter MacMillan Cancer Center, who himself is building machine learning based risk prediction models, is asking, how did you overcome and avoid the difficulties encountered by the EPIC sepsis model?
Yeah, so we actually we experimented with that one. So we actually used the Epic Sepsis model first. And that was something that I remember very distinctly getting a number of questions from our nurses about what was going on, why did this fire? It made very little sense. So we played with it. I wasn't particularly excited about it. I think it was a step up from using something like the systemic inflammatory response syndrome criteria to screen for sepsis, but wasn't that impressed. Now, again, a lot of this is right time, right place, right people, right? What's that environment that you're in? I had the benefit of having Dr. Namati kind of join as a partner shortly after the EPIC sepsis model. And we very clearly, had an explicit goal to bring a machine learning model to UCSD that could outperform that model. And so we have, kind of compared the two. We found that our model was, had a better test characteristics across all the typical sensitivity, specificity, AUC, positive predictive value, et cetera.
Yeah. Thank you. And then just going a little bit deeper, Tim Fazio, who is our Director of Clinical Informatics at the Royal Melbourne Hospital, is asking, I think, a very important question, which is noting that the success of this relied on much more than just the model, and instead the architecture and the pipelines. Where would you start in trying to transport this to an Australian context?
Yeah, I think, well, I think this is where it comes to the implementation. And I think probably the question that everyone that does any kind of AI tool asks themselves is, how much is the model and how much is the implementation? Right. And oftentimes, the model is what gets the excitement, right? They hear there's a new technology, right? We're really, really excited about that. But I think it's kind of taking a step back and saying, hey, even the best tool in the world, if it's not well implemented, isn't going to work. You're going to fall flat. And so that was a heavy emphasis that I had when we started, was to really kind of go through with a good framework about how this could actually be done, which takes into to account the constraints of your institution, right? But also the strengths. And so we really played up, our strengths were obviously, kind of getting this model into the bedside relatively quickly, taking away a lot of the barriers, but then also recognizing that, it's going to be the end user, how they use it, and focusing on that to build those connections, to bring in the end user from a very, very early stage, to make sure that we were doing the right thing became absolutely critical. And that's what I'd recommend, right, for you guys too, right? It's finding, the right application of an AI tool that meets a need to really bring in those end users early on to make sure they're happy with what's going on, rather than just throwing a new tool at them. They're like, what is going on here?
Yeah. And how much time was spent on the data engineering for the data pipelines to allow the model to take data from the EMR and back into the EMR after processing it? Could you give a sense of the timeline and the
Yeah,
workforce required for
that.
technical integration?
So we had you saw Dr. Aaron Bucina, his picture. That was something that probably took about maybe a year and a half of his PhD to kind of get going. He did part of it. And again, it's kudos to our Epic team too, that we have at UCSD for kind of working with him to kind of make sure the outputs landed in the appropriate location. But yeah, it was probably about a year and a half or so to kind of get that done. I think now it's probably a little bit easier because I think enough institutions have, kind of gone through and there's more of a cookbook, so to speak, about how this can be done. But him and our Epic folks were absolutely instrumental in making this happen.
Great. There's a couple of questions from different folk. Talking about like the mechanism of alerting the clinical team. One of our senior researchers asks if nurses are able to initiate actions,
Yeah,
as a process to contribute to time to action. And then another colleague asks whether Composer used a centralized distribution approach, where the prediction is sent to a single clinician who then contacts the doctor who's
yeah,
working
yeah.
or whether it's distributed and sent directly to the care teams. Could you talk a little bit about how you thought through those alert methods?
Yeah. So I think what I'll say is that usually when it comes to sepsis care, and at least this has been my experience in San Diego, is that oftentimes physicians get in the way. They think they're always right, and they don't like to kind of hear that, something else could be going besides what they think. And so our nurses do have the ability to start standing orders that check blood cultures, lactate, metabolic panel, and a CBC if they are concerned about sepsis. It doesn't happen much, but they have that option. They do not start antibiotics, and our code nurses at UCSD are allowed to give a small amount of a fluid bolus if someone is hypotensive. But we do maintain a physician that is the one that would oversee the administration of antibiotics. When it comes to the design that we have, the initial one we had was heavily nurse focused, and that's the best practice advisory that you saw here. And what that looks like um, is that it goes to the nurse. We selected the nurse, like I mentioned. My opinion is that doctors get in the way, but also it's just a practicality of our instance of Epic because if the provider had, let's say, 16 patients that they're taking care of, unless that instance for a particular patient was open, that they would not get the alert. So with the fact that our nurses had a much smaller number of patients, that became really, really critical in making sure they'd get it quickly. Now, what we have done for the physicians is we give them a gentle nudge. In our trackboard, they can see if an alert has fired, the patient's name will turn blue. So there is, some kind of an approach that allows to kind of share the cognitive a shared mental model when the notification goes off. And we have stressed, some standardized scripts to our nurses when relaying this information to physicians about why they're doing it so they don't feel that they're kind of alone, so to speak. So we found that's helpful. And what we're doing right now actually is with the advent of, more of our large language models, we're actually going to start showing the best practice advisory to the physician, give them a differential diagnosis about what's going on. So,
That's great. Now, pivoting slightly now to the quality improvement project, one of our colleagues from the Royal Children's Hospital is asking for clarification on the near real-time feedback. Was that next day? Was it next
yeah,
week? How close do you think you should get it to the decision um,
yeah.
to optimize reinforcement?
Yeah, sooner is better. That's obviously going to be right with anything that we do. The trade-off that you're going to deal with is if it's too quick, they might not be septic, and then you're giving someone feedback on something that's when it's not present, and you obviously wait too long. So the way that we did it with this was at the time of discharge. So that gave us enough time to kind of go through and make sure the case was appropriate. The vast majority of cases were less than a week. There was a few outliers that were more than a few months of very, very sick people, and those again, the feedback there is going to be less impactful.
Thank you. A couple of questions regarding the biomarkers you commented on. One colleague is wondering what kind of digital biomarkers you have identified so far for early diagnosis. And another is whether you've considered integrating novel sepsis blood tests, Cytovale, Immune Express, and Inflammatrix, into the composer model itself.
Yeah. So the second question is probably the easier one because we have, we've just finished some studies with Inflammatix about the added utility of how if the composer alert says sepsis could be possible, what's the added benefit of adding on that test. And if you don't know what inflammatics is or the trivarity test, it looks at 27, or it looks at the host response through 27 mRNAs that it picks up on, and is usually very good at picking up on either bacterial, viral, and risk of deterioration within 7 days. So adding inflammatics on was quite useful. We really saw that for cases where there was uncertainty, that test really kind of, okay, pushed you, yes, this is going to be bacterial infection versus not. The downsides are it's quite expensive. And it's, kind of that implementation workflow about what it looks like for a test that's close to $1,000. Does it make sense to kind of fire off? So we're looking at some other approaches there for things. And in terms of, I guess, quote unquote, true digital biomarkers, I, that is something that we don't have a true digital biomarker about kind of what some of these look like, but it's something that that I think is quite interesting. So
Great. And there's a couple of technical questions of people really engaged on the machine learning side are weighing in. One was about conformal prediction, and Jiva was asking what would be the acceptance criteria? Can you consider some inserts such as nulls and treat them as such? So I guess it's about the training of the model based on the lecture.
yeah. So that's something again that that this is and I'll refer you to the paper that we put out in 2021. This is really where it becomes kind of what's your threshold, right? For kind of overcalling sepsis, undercalling sepsis, or kind of what we did, which was some kind of happy medium there. You're certainly right. You could just put nulls in for those approaches, and it's based on the kind of the intent of that question. I assume the person asking it is very well familiar too with how to deal with data missingness and strategies that that can go there. We certainly do use a number of strategies to impute missing values, but I'd have to refer you to the manuscript. It wasn't me that went through and very specifically did the nuances about how that, what would be the added value of using a null versus just kind of, rejecting it.
Yeah. A couple more questions about generalizability. One is the obvious question of how it's performed in deployed in other institutions. But perhaps a more nuanced question is how does it perform outside of the ED in your same institution on ward
Yeah.
patients?
Yeah, so the answer to both of those is to be determined. So we are going to get this in our hospital wards. I think the tricky thing is that for any tool like this, right, it's trained on ED data predominantly, and so releasing it into the hospital wards where it's a much different timing of vital signs, lab results, and there's honestly a lot more uncertainty. Means that it's going to hit some pitfalls unless it's specifically retrained there. With the generalizability, we do have some other institutions that we're using through a grant from the University of California through a federated learning approach to kind of see how it performs at those institutions. But one of the challenges, right, for a homegrown model like this is how do we get this into the EHR, right? It's not a cheap thing to kind of run this through. And unless, as a start, there is significant grant funding or, an industry partner that is willing to kind of buy this and put a good amount down for this, it becomes quite challenging.
Thanks. That's a great answer. Um, the Belinda Ambrose had a question that I think is important is there a gap between early warning of possible sepsis being validated against confirmed sepsis cases? And so is the purpose to avoid sepsis, so not picking up the cases is a good thing? Like how does this reinforcement learning loop happen once the model's implemented, I suppose is one of the questions.
Can you just rephrase that one more time? Make sure I
Yeah.
understand the question
Well,
appropriately.
I think what Belinda's asking is if you start to do a good job of identifying early sepsis, and so then it no longer becomes confirmed sepsis, and then you're in other phases of model development, such as revalidation the model or reinforcement learning. How does that impact um, the training loop, the inevitable retraining loop or revalidation
Yeah. So
machine?
that is a very good question, right? Obviously, right, if in a perfect tool like this, right, that's designed to catch sepsis before it happens, right? If you get everything on and you prevent the development of sepsis, that's a huge win. But how does that kind of be, how is that measured? It's quite difficult. I think the other thing that makes it quite difficult goes back to when I mentioned there's different definitions of sepsis and how are these operationalized? Because sometimes it's as simple as looking people that have, a few abnormal vital signs is all that it takes to get them tagged,
Mm.
versus what we're trying to get is really look at people that have that life-threatening response to an organ damage in response to infection. So that is one of the things that makes sepsis models so difficult to study, is that it's highly dependent on the definitions that you use and what your model is looking at doing. Because on the flip side, what I could do is say, hey, I now use a model that goes through and identifies people that would meet criteria, put a billing diagnosis in for sepsis and say mortality is a lot better, because we've tagged a bunch of people that don't have that spirit of the word sepsis, but merely just have a few little abnormalities. And we say, boom, what providers were thinking was just a simple UTI. Now we're going to have that label change. So it's a big question. And again, there's not a perfect answer on how that works out.
Okay, and last question again from Tim, which is, was there any, he's used the term safety signals, but were there any lessons learned in the altered management of the sepsis mimics? You had mentioned GI and bleed
Yeah.
in one perspective. Was there a delay to appropriate care in false positives, or were there improved because the provider
Yeah.
team was at least being alerted that the patient was sick?
So I don't have the data on that. I think what I can tell you is that the concerns that I've had that I do we do need to measure would be things like inappropriate treatments, unnecessary blood cultures, unnecessary antibiotics, where people kind of jump in and say, this says sepsis. I'm not going to think critically about the patient, but rather just administer therapies because the model says that. So I think that's one very important thing to kind of measure. We have not also taken a look to see, right, are people missing diagnoses because this happens? Anecdotally, I don't think it happens much, but I think it is something that is worth taking a look at. Is kind of that human machine interaction about how that impacts decision making, because ultimately, right, this is meant to be a tool. It is not meant to replace human decision making, but rather to go for a much more of a symbiotic relationship between the two.
Yeah, that's a great perspective. Gabe, thanks so much for staying up late to give us a presentation today. And audience, thanks so much for tuning in and thanks for all your great, thoughtful questions. Really appreciate
Yep.
it. And look forward to our next seminar series. There's not going to be one in June, unfortunately, but we hope to secure a speaker for July. Please use the QR code on the screen to sign up for updates of upcoming speakers. And Gabe, once again, thank you for your expertise and your time. Appreciate you.
Of course. Take care. Thank you so much for the invite.